Good afternoon, everyone. The session is ready to begin. The session is sponsored by the Healthcare Cost Institute, and our appreciation goes out to HCCI for their support. Andrea Clark from Barry Dunn will moderate this session. Andrea, you have the mic.
Okay. Thank you, Charles. Welcome to our final breakout session on linking social determinants of health data with other data assets. We've got three great presentations for you this afternoon. So without further ado, I will turn it over to Alberto Ortega Hinojosa and Sydney Lufsey of IMPAC. Dr. Ortega is a senior associate and data visualization lead at IMPAC. He has more than 14 years of research experience, including using geographic information systems, public health practice, policy analysis, and stakeholder-driven presentation of data. One of his primary interests is the intersection of place and health. At IMPAC, Dr. Ortega has worked on a broad range of projects. These include evaluating CDC-funded efforts to prevent chronic disease by targeting social determinants of health, and leading the design and development of Tableau data visualization solutions. Sydney Lufsey is a health analyst at IMPAC with a background in public health and a focus on measuring social determinants of health and social needs. She has a diverse experience in the public and private sectors, providing support to various government agencies at both the local and federal level. Ms. Lufsey's current projects focus on SDOH research and data visualization strategies to inform interventions. Specifically, she has worked on an AHRQ-funded project to develop an environmental scan and SDOH policy data sources, and she currently maintains IMPAC's SDOH action tool. They'll be presenting on visualizing opportunities and disparities with the social determinants of health dashboard action tool. And just a reminder that we'll generally hold questions until all three presenters are finished, unless there is something particularly timely that comes up in the chat. Sydney and Alberto.
Thank you so much for the introduction, Andrea. We're really excited to be here and to get to share this tool with all of you. Just a very brief background about IMPAC. We are both part of IMPAC Health, and IMPAC is a global policy research and analytics firm delivering evidence that shapes the world. And Sydney will get us kicked off by talking about what the elements of the tool are.
Yeah, thanks, Alberto. So IMPAC's Social Determinant of Health Action Tool offers three unique dashboards for users to explore SDOH and health outcomes within communities of their choice. I'll just briefly describe the three dashboards here, but I'll get into further detail later in the presentation on them. The first dashboard is the Health Outcome Dashboard, and this allows users to explore selected health outcomes such as diabetes or hypertension and learn more on how the evidence-based SDOH contribute to that health outcome within their selected community. And the next dashboard is the SDOH Drill Down Dashboard, and this really allows the user to hone in and drill down on a specific SDOH of interest and see how it affects their community. And the last dashboard is the Community Comparison Dashboard, which allows users to explore two communities and see how they compare on a specific SDOH measure.
Right, so as Sydney mentioned, we're looking at a number of SDOH measures. But before we get there, we just wanted to set the stage for us and also for the other two panelists today about what are social determinants of health and why they are important. So social determinants of health are elements of the social and physical environment that affect health outcomes such as mortality, morbidity, life expectancy. And these are really important to understand because many of these are modifiable, and we as a society can implement programs and policies that target each of these, such as economic stability and neighborhood and physical environment, such as parks and walkability, access to food, access to healthcare coverage. So with that in mind, going into the next slide, some key facts about social determinants of health, which is that they can explain up to 80% of health outcomes, such as life expectancy, and up to 85% of the utilization and costs for healthcare services in the country. So given that, this is something that is of very high interest to many of us, and why we have focused on social determinants of health for our dashboard. One of the key elements that we were focusing on in thinking about how we are linking data really started about almost a year ago now, actually, last fall through an AHRQ challenge. So that's the Agency for Healthcare Research and Quality. And the main goal was to link different data systems to make them accessible to the public. And because of that, we thought about not just how to link information from different databases, but also how to link information that we have with space. So where are these different outcomes happening? And also thinking about the linkage through different communities. So not just what is happening where I live, but what is happening in similar communities so that we can use that information to inform our decisions and also to share best practices and see what is happening across the different parts of the US. With this tool also, we chose Tableau Public because of its ability to be downloadable and shareable, and also add your own data once you download it locally.
Yeah, thanks Alberto for describing why we created the tool. I'll now take this time to describe how we created it. We designed the tool in 4 phases. First, the research phase, where we conducted a literature review to explore the evidence-based relationships between SDOH and the health outcomes within the tool. We went into the design phase, where we took a human-centered design approach to ensure that the tool was user-friendly and the content was interpretable. And then next, we put the tool through 2 rounds of user testing with our target audience, which I will describe shortly, and incorporated that feedback. And lastly, something that we're continuously doing is disseminating the tool, its information and data through Impact's webinars and conferences such as this. And we're always improving the tool through both internal and external feedback, and also adding new evidence-based insights based on ongoing research. So as I mentioned about the target audience, we gathered interested test users through both internal connections and networks that we created at conferences like data health conferences such as this. And our target audience is health plans, local community workers, community-based organizations, healthcare providers, healthcare improvement organizations, policymakers, and other on-the-ground partners that want to make an impact in their community by improving health outcomes and producing actionable results. So just briefly, how we did this was we demonstrated the tool to our target audience and the users that we identified with a webinar distributed a user testing guide. We then collected, as I mentioned before, user feedback 2 times and updated the tool based on that user feedback. And we're constantly adding that additional feedback and updating the tool accordingly to ensure that it does meet the needs of our target audience.
One key factor about the SDOH action tool is that this is really a living tool, and we plan to continue maintaining it, make sure that the data that we have is the most recent, and that we also continue to gather feedback from events like this one to improve the usability, and also who can use this to implement policy or programs within their work. We started with 3 health outcomes. Again, as Sydney mentioned, these were based on the literature and are evidence-based with respect to the SDOH variables that we chose. And right now we have diabetes, hypertension, and chronic disease in the tool, but we'll be soon adding COVID-19 outcome data as well as asthma. Just some example variables include walkability, food access, health insurance access, and the Gini index, which is income disparity within a community. Going into where we obtain the data, we have a broad set of data sources, and this is just a couple to highlight those examples. So we have American Community Survey for additional information on income, poverty rate, unemployment rate, but also some less common sources such as the Food Access Research Atlas and the Mapping Medicare Disparities tool for our health outcome. And as I noted, we continue to add sources and to make sure that these are maintained with the latest release that's available.
Yeah, thanks, Alberto. And as I mentioned before, when designing this tool, we took a human-centered design approach. And so we wanted to leverage the data that was out there in a meaningful way and empower our users, our target audience, as I mentioned before, to drive insight in a way that they would not be able to analyze the data themselves. So we put it into this visualization to make it easier for them. And several design considerations that we had was we wanted to make sure that one, the data was complete. And so all the variables within the tool are at least 95% complete at the census tract level for SDOH measures and at the county level for health outcome measures. We also wanted to make sure that the tool is interpretable. So all variables have been normalized for comparability. For example, all the variables are shown as either percentages, rates, or indices. And we wanted to make sure that the tool is scalable. So, users are able to aggregate the SDOH and health outcome data to the state and national levels for comparisons. And what this means is that the tool automatically summarizes the census tract level data to the state and national level averages. We also wanted to make sure that the tool was intuitive. So examples of this is we added features to the tool that automatically highlight the bars on the graph. So it better orients the user in terms of where their census tract or zip code is located. We also added emoticons and colors into the performance key so a user could more readily understand where their selected community ranks on a specific SDOH. So as I mentioned on how we incorporated the feedback for this tool, this chart shows on the left some quotes from the first round of user feedback, and on the right, the appropriate updates that we made to accommodate that feedback. So for example, several of our users said that some more novice users or people not fully ingrained in the data or not familiar with public health may struggle to understand what a census tract is and how to find their census tract. To accommodate this, we added a zip code level filter and geographic layer to the tool. So users are able to search the tool for their specific zip code, and this helps orient them so they get a better understanding of where their census tract is located.
Right, so now that we've described some of the background for our tool and the impetus for it, we're going to run through a use case walkthrough where this is our landing page. And based on this landing page, you can choose which of the dashboards you can interact with to discover different bits of insights from the data. And I will be playing the role of a community-based organization who recently received a grant. So Sydney, I am really excited to learn about this tool, and I'm hoping that I can better target the grant that I just received on different chronic diseases like obesity and diabetes. And I was hoping that you could walk me through the tool so that I can understand how best to use it and work with my grant.
Yeah, I think this is actually a great tool for your organization. And I would first draw your attention to the first dashboard, the health outcome dashboard, where you can select a specific state of interest and health outcome of interest as you're interested in diabetes. Then after selecting that, the tool will populate the demographic information on the state that you selected. And you can actually hover your mouse over specific counties within the state to get a better understanding of the individual county's demographic information. If you scroll down on the tool, you're able to then select a county and or census tract of interest and a point of reference that really allows the tool to be a little bit more scalable. And this helps the user understand how a census tract or community that you select compares to the county, state, or national averages on that specific SDOH measure.
Just to make sure that I understand that, Sydney, when you say the point of reference, that means that the benchmark is how I compare on average to other census tracts in the county or to all the census tracts in the state or to all the census tracts in the nation. Is that correct?
Yes, exactly, which is what makes this tool so much different and a little bit more scalable than others. And so one thing that is also great about this tool is the performance key. As I mentioned earlier, it makes it a little bit more intuitive and user-friendly for even more novice users. But once you do select a health outcome, the SDOH that we've already researched in our evidence base populate at the bottom of the tool, and you're able to see where different census tracts within your community rank on that specific indicator.
Great, thanks, Sydney. So what if I want to learn more about the specifics of the population within my county, where would I go for that?
Yeah, so I just flipped to the next slide, which is the SDOH drill down dashboard. And this would allow you to really drill down into a specific SDOH of interest, in this case, walkability, and get a better understanding of the specific communities such as Kent counties, demographic information, and how they rank on walkability. And here's the map and how it does that. Again, you can hover your mouse to get a better picture of a specific census tract.
That's great. And then the last question that I have is, now that I've gotten down to the census tract and can see that information, what if I want to know about a similar county somewhere else in the US where maybe I can see some lessons learned or know more about how others have approached targeting these SDOHs?
Yeah, good point. So then I would point you in the direction of our third dashboard, the community comparison dashboard. And this would be really great for a CBO like yourself who wants to figure out how to allocate funding best. You can compare your community to another community, and if for some reason they're doing something really great and score really high on walkability, you can even reach out to their CBO and get a better idea of what kind of programming and funding they're doing that has been successful. So you just select a community of interest, select another community of interest, and added is that similar communities to one you select will pre-populate within the tool, similar to demographic information. Communities that have similar demographic information to the communities selected will populate within the tool. And this just allows a little ease for the user so they don't have to already know what communities to compare it to. You'll then scroll down and be able to compare the maps as previously stated and get a better understanding. And if you scroll down further, you can get a better depiction of the demographic information between the two communities.
Thank you, Sydney. So I know we are a little short on time, so I'll very briefly just highlight a couple of limitations and challenges. And one of them is data, is that we can often have lags in data reporting, as well as the availability of the resolution of the data. So the granularity of not always having data at the location that you would like, such as census block, or the really minutia where sometimes SDOH is having their influence. And of course, having data that is available nationally in a standardized way. Those are some of the key aspects of it. And since I know we're short on time, I will leave it on that and pass it back to you, Sydney.
Yeah, so here are just some quotes, and I'll leave up and we'll send the slides out later, from our stakeholders in the second round of user testing. And I think it just really depicts how impactful the tool can be and really produce those actionable results that I was mentioning earlier. If you do have further questions, our contact information is on the slides. Feel free to reach out to us if you have questions about the tool or if you even want a demo of the tool. And we appreciate you sitting in on this presentation.
Great, thank you.
Andrea, you're on mute.
Great. Thanks, folks. Next up, we have Sam Chick from OnPoint, who's going to be presenting on linking APCD and social determinants of health data for enriched public reporting. Sam is part of the process and product development team at OnPoint Health Data, spearheading data and analytic innovation for the organization. Mr. Chick has a strong background in healthcare claims analysis and data science, with specific expertise in the areas of data extraction, manipulation, analysis, and reporting. He is proficient in the development of summary reporting specifications and in the detailed methods for addressing client questions and needs based on technical knowledge and data sources.
Thanks, Andrea. Hopefully everybody can see me, hear me, and see my screen here. So hello, thanks all for coming. My name is Sam Chick. I'm coming to you from the guest bedroom of my Portland, Maine apartment. And over the next 15 minutes, I'm gonna tell you about a project that we undertook last year where we chose to incorporate social determinant of health data into our reporting. Thank you to Sydney and Alberto for helping to explain earlier on why this type of data is important. I'm not gonna rehash that, but suffice to say, it presents a lot of really interesting opportunities for analyzing healthcare data. So I'm gonna explain how we did it, what challenges we faced along the way, what outcomes we achieved, and finally, what lessons we took away from that experience. So without any more preamble, I'll get right into it here. So going in, it's important to know that any organization that maintains and especially pays for an APCD knows that it's important to be able to demonstrate the value of that APCD not only to your peers and to other organizations, but also to the general public. That's why OnPoint was initially tasked with creating a publicly available reporting tool using data from the Washington State APCD. After some deliberation, it was decided that this tool was going to be made up of 3 different interactive dashboards. 2 of these were going to focus solely on claims-based measures, and these include measures such as chronic condition and disease prevalence, things like diabetes prevalence, breast cancer prevalence, HEDIS quality measures. These measure how the quality with which patients are receiving care within an organization. And lastly, utilization and cost metrics. So what services are members using and how much are they paying for them? However, OnPoint also took this opportunity to incorporate publicly available social determinants of health data to produce a 3rd dashboard that allowed users to directly examine the relationships between SDOH measures and those outcome measures that I had just listed. These reports were intended to be made publicly available to maximize the size of their potential audience. This also meant that they needed to be designed with strict data security practices in mind, and I will talk about that at length in a few moments here. So how do we actually go about doing this? To link our APCD and SDOH data together, we first began by establishing our base population. And in this case, that was the 6.7 million members contained in the Washington State All-Payer Claims Database. For the purposes of these reports, we included data from calendar year 2015 through 2017, and the intent of this was to provide the opportunity for some longitudinal analysis instead of just a single point in time. After due consideration, we also settled on a list of 15 claims-based measures that we thought would be both generally applicable and analytically valuable. So measures that would apply to as many people in our base population as possible. SDOH measures were created using data from the US Census Bureau's American Community Survey, also known as ACS. I believe Alberto mentioned this as a data source for impacts tool as well. And these, to reiterate, include measures such as percent of the population living below the poverty line, percent of the population is unemployed, the percent that's uninsured, the percent that's enrolled in Medicaid, so on and so on. Once we'd settled on these measures, we needed to determine the most granular level at which these 2 data sources could be linked. We ultimately decided on zip code since it was granular enough to facilitate the type of analysis that we wanted to perform, but it was also readily available in both data sources at once. So once the linkage was performed, we had obtained our initial analysis data set, and we were ready to hit the ground running and start building our reports right away. Because that's how this kind of thing always goes. But it turns out that reporting is never quite as straightforward as we initially assumed. So we faced generously several challenges on this project, but none of them were quite so crucial to the success of it as the challenge of balancing data security with analytic value and flexibility. So anyone who's worked with sensitive data can tell you that data security and blinding, though vital, I'm not here to disparage data security, but although vital can often be a frustrating barrier to creating functional reports. Small populations need to be blinded or removed outright, and data on the back end of a report often needs to be pre-aggregated to guard against a potential data breach. And this especially can wreak havoc on the flexibility of an interactive report. In the end, though, we did find ways to work around these constraints. The linkage from the APCD to SDOH data already had necessitated the aggregation of APCD data to the zip code level. From here, we identified additional data groupers that we knew would be analytically valuable. So these would be fields that a potential user would want to group and filter by within a dashboard. So things like age, gender, reporting year, major payer. From here, we needed to determine a cutoff that would be, a cutoff for what would need to be blinded in these reports. 30 is the number we chose, 30, greater than 30 members per cell. This aligns with the reporting guidelines for CMS data, and it's a number that gets used a lot in reporting. So next we had to assess, with our cutoff in mind, we had to assess which combinations of these grouping fields yielded the fewest number of, yielded the fewest number of groups with fewer members than our cutoff. So if we were going to use age, gender, and reporting year all as grouping fields, how much data do we need to throw out because the number of people in a cell falls below 30. Some grouping fields were dropped because of this, because they grouped the data too granularly, but some were also adapted to make them more usable within this framework. So age, for example, became age band. So instead of having 100 plus potential values for one for every age, became less than 10 after we had grouped ages together. If you attended last year's conference and you have a really outstanding memory, you might remember that I spoke on this spoke on a similar topic to this last year, the creation of public use data sets, and a lot of these principles were pulled directly from that and apply a lot more generally to creating public data sets for any number of uses. So using these methods, we were able to strike a healthy balance, I think, between retaining as much non-blinded data as possible and keeping the data sets, flexible enough to facilitate different types of analysis. So what actually happened? Using our now safe for public reporting data set, we were able to assemble 3 dashboards in Tableau, and similar to Alberto and Sydney, published them using Tableau Public. They were then embedded within our client's website where anybody with a web browser and internet access could view them. Users could use these dashboards to track outcome results over time, by geography, and by various demographic factors. They could also examine year-over-year changes and measures for various groups and cohorts. Lastly, as I alluded to before, they could leverage the built-in capabilities of Tableau to model the interactions between SDOH data and outcome measures in real time to determine whether significant relationships exist between them. The example I've included in this slide shows what turned out to be a statistically significant linear relationship between Medicaid enrollment and inpatient facility utilization. So to recap what we took away from this project, what did we learn? One, we learned that blending SDOH data with your APCD can create very interesting and robust and insightful interactive reporting that helps to demonstrate the value of your APCD. 2, by simplifying the process of modeling the interactions between SDOH measures and outcomes, we were able to offer increased opportunity to discern meaningful relationships between them. And 3rd, that it is indeed possible to preserve the value and granularity of an analytic data set while still adhering to strict data security practices. I've also included a link here to the website where these reports were published. I'd encourage you, if you have time, to go check them out for yourself. Let us know what you think. So that is everything I have. Thank you again for coming and listening to me. I'd be happy to answer any questions you have either at the end of this session or offline over email. And I will turn things back over to Andrea.
Thank you very much, Sam. Our final presentation for the session is by Shubha Ghosh and Charles, our NADO's own Charles Hawley. Shubha Ghosh is a social work researcher with more than 10 years of experience conducting health research globally and using research insights to design innovative health interventions. Dr. Ghosh's experience spans uses of census data as well as collecting primary data for various research purposes. She has published widely in high-impact peer-reviewed journals and received several grants to conduct research globally. Dr. Ghosh currently serves as a senior program manager at SEIU 775 Benefits Group with the Research Insights and Innovations team. Charles William Hawley is a research consultant and healthcare analyst with experience in the public and private sectors. Charles has worked extensively with all payer claims databases and hospital discharge data. His work with the administrative healthcare data focuses on data governance, infrastructure development, analyzing the cost and quality of care, and promoting transparency. Charles currently serves as the Director of Projects at the National Association of Health Data Organizations.
Okay, so good afternoon, everyone. It's really interesting to hear all the wonderful work we have been doing in the area of social determinants of health. And we are here to talk about our work at the organization, the SEIU 775 Benefits Group, where we looked at or tried to identify disparities in chronic disease by linking medical insurance claims data with the county health ranking data. Charles, could you go to the next slide? Okay, so what is the goal of this work? So the goal of this work is first to understand, the prevalence of chronic disease in the population of home care workers, and also to find out that what is the relationship of these chronic diseases with the various social determinant factors that are leading to disparities in the health outcomes, disparities in health outcomes. And we specifically focus on Washington's home care aid because that's the population that our organization supports. And you can see that we have two goals here. One is a research goal and the other is the business goal. So in the research part, of course, it's important, to understand, like, if you do a tool or a visualization, a lot of the work at the background goes into trying to identify whether what you're visualizing is important and is statistically significant. So that's a research piece. And using that information, we created a visualization tool that is currently helping the organization to make evidence-based decisions, and also the tool that we created is actually sustainable and cost-effective. And the organization, as I said, is using it for its resource allocation and evaluation of programs. So the next one. So who are the home care aides? So the home care aides are actually, people who care for older adults and people with disabilities who live independently in the community. And SEIU 775 Benefits Group is one of the largest organization in the country, actually, to support home care aides by providing them with health, education, and also with retirement benefits. And also to briefly say that most of the Washington home care aides, and that's the data I'll be talking about, are socioeconomically disadvantaged in terms of the fact that, okay, I move to the next slide. Okay, so just back up a little bit. In terms of why was this project important? It was important because, in general, and I've been in the caregiving research for the past 10 years now, we know that caregivers in general, not the home care aides specifically, have poor physical health and mental health outcomes, and the rates that are significantly higher compared to similar age non-caregiving peers. And some of my own research shows that they have higher rates of early mortality and higher rates of morbidity too, compared to their similar age non-caregiving peers. And while that's the health part of it, but also in terms of socioeconomic factors, and specific to the Washington caregivers, is that they are primarily, the average age, as you can see, is 48, but primarily they are older adults who are also caring for older adults and people with disabilities, and predominantly female, and also have socioeconomic disadvantages in terms of their low income, lower levels of education. The median income is is 35,000 to 39,000, you can see. So, you know, so caregivers, you can see, has two things going on. One is that they are socioeconomically disadvantaged, and on the other hand, because of the care that they do, they also are vulnerable to a lot of poor health outcomes that is attributed to the stress and the hard work that comes with caring for somebody with chronic disability or age-related issues. So Charles, the next slide. So now that we know, the goal of the organization was primarily, or the task that was given, was to understand, okay, what are the disparities in the population? And we know from previous literature, and I'm focusing especially only on the caregiving literature right now, because this work is specific to caregivers, is that, you know, caregivers they do not function in a vacuum, they function in different systems. And there are a lot of these factors, the barriers and facilitators as each of these levels and systems, which is part of the ecological mapping, what we call it. They all impact your individual health outcomes. However, most of the disparity research that has happened in the area of caregiving has only looked at individual level factors like age and gender and race to some extent. So none of the macro factors or even the meso factors have ever been touched on. And most of the evidence comes from, you know, smallish surveys, or even sometimes large surveys. You have the caregiver survey, and it's mostly cross-sectional data. And so there are limitations, and there are huge gaps in the literature. And the purpose of this work is not only fill in the research gap, but also to generate evidence in such a way that the organization can use it. So the next slide, Charles. So as I said, the organization in general knows that, you know, you have the disparities exists in general, and then you have the caregivers who have poor health, and there are also socioeconomic disparities existing. What they do not know is how the social determinants of health disparities among the caregivers at various levels work. So the task, as I said, was done to actually influence both the organization, which is, as I said, a benefits group, and also a health carrier, which are Kaiser and Aetna, who are the primary health carriers, inform how, on the one hand, the organization as to how they can use this information to design better interventions, how to prioritize their resource, and also longitudinally track performance, but also to tell our carriers that, see, that we are using your health insurance data and using the claims data to create this work, and we are finding these gaps or these disparities that are existing. So there are areas in which you can actually make an impact, and there are areas where the organization can make an impact. But I think an insight and an insight like this is helpful to both the organization as well as to carriers to come together and make more effective decisions and see how we can devise meaningful intervention in partnership with the carriers to make effective dent in health outcomes of people. So the next slide. Is the aims. So of course, the first aim is to calculate the prevalence of chronic disease and comorbidities and identify which of the factors are, you know, which of the social determinants of health factors are associated with disparities. And we were interested not just in chronic disease, but also in comorbidity, that is somebody having more than one chronic disease, which is fairly common in older adults. And so we wanted to see like whether there are any special interaction that's going on. And of course, as an outcome, create a visualization tool that's easy for the organization to use, that is user-friendly and something that is sustainable and can be looped into the organizational workflow. So, those were the three aims in which we started this project. So we'll go to the next slide, Charles. So the methods, and Charles will take it up from here.
All right, thank you, Shubha. So bear with me here. Sorry, I'm juggling screens. So let me speak to the data sources first. So the benefits group, an important note here is that the benefits group is a self-funded employer. And the group receives claims from its insurance carriers, which are Kaiser Washington, Kaiser Northwest, and Aetna. They're received monthly and processed in a way that's really similar to anyone who's worked with an all-payer claims database. And specifically, the data are collected and managed by Milliman MedInsight. So what we did is we went and we actually extracted a limited data set out of the MedInsight system. At the time, I mentioned that there are 3 carriers. At the time, we only used Kaiser Washington data because the others just hadn't moved into production yet. So when we extracted the limited data set, that was to address organizational concerns about privacy and security given PHI. And so we ultimately ended up with about 27,000 HCAs enrolled between 2016 and 2018. And we, on the other sort of hand of this, if you will, we pulled some data out of County Health Rankings. County Health Rankings is a website that is administered by the University of Wisconsin and Robert Wood Johnson Foundation. They aggregate at the county level social determinants metrics collected via surveys administered by state and federal government. For example, BRFSS and the American Community Survey, although that's not an exhaustive list. So we took those data and then, and essentially we used we didn't extract full addresses from MedInsight and store those locally, but we do have HCA addresses as part of the medical claims. And so we use those to join these 2 data sources at the county level. And okay, so from there, we took and categorized the ICD-10 codes based on, well, I guess based on ICD-10 codes, but we categorized those diagnosis codes with consultation from the benefits group's medical director and with support from some students at the University of Washington's iSchool, some interns. They helped us with the categorization as well. So the logic for selection was based on prevalence and actionability. And it's interesting to note that we don't necessarily present this here, but we had multiple comorbidity combinations, if you will, where that were more common than a single chronic disease. And so we ended up limiting down to just this kind of set, which I called the chronic diseases of interest. Yeah, this is ultimately where we landed. And then some of the results here. I'll kind of push through these. Oh, this works better than I thought. Perfect. So these are just some quick kind of descriptive results that show a little bit of the distribution. So Shubha mentioned that comorbidities are fairly common in older adults and that our population is mostly comprised of older adults. So you'll notice in the table on the left, kind of supporting that understanding that home care aides are generally sicker. We note a high rate of chronic disease. We also noticed that half of Washington's HCAs or home care aides have a chronic disease of interest with a comorbidity. And then on the right here, you can kind of see the distribution of comorbidities for the population. So in this case, 0 represents like a single chronic disease without a comorbidity, and then 1 would be kind of like 2 chronic diseases of interest here. Let me move to the next one. And then this is the distribution in terms of the prevalence of the chronic disease of interest. So you can see that in this population, musculoskeletal conditions are fairly common. And then you get quickly into what I think of as maybe a little bit more expected results with hypertension and even mental health, diabetes, etc. Let me move into this one. So then, as Shubha mentioned, we did some modeling as part of the work so that we were really visualizing these relationships that were most meaningful. So we partnered with Clyde Dent, a statistician consultant with experience at USC School of Medicine and the Oregon Health Authority. Clyde helped us run a bivariate analysis of each of our HCA demographics and county social determinant variables and take a look at the effect on both the chronic disease and comorbidities before ultimately modeling to control for the interaction effects across these. Here what we're presenting is some of these variables from the model. I want to note one thing as you guys are looking at this first and foremost. You'll notice that there's differences in the units of analysis here across these variables again, and that's baked in, right? Some of these are at a caregiver level or individual level, and then others are at the county level. But even at the county level, you'll notice that the units are different. So we have percentages, US dollars, a ratio, and a yes or no presence of water violation. So given those differences, I need to look at time real quick. Given those differences in units, we standardized the units so that they're a little bit easier to interpret and we could figure out which was having the greatest effect. Yeah, so and there are some binary variables in here which create these kind of likelihood of being female or likelihood of a water violation. So that's why the interpretation there. As I mentioned, this is not the entire model. These are just some of the areas of interest that ultimately wound up in kind of the visualization. I do want to note that we controlled for member eligibility since there's considerable month-to-month variability in work history and eligibility for this population. The reasons that we left out variables that are in the model from the visualization was really trying to strike this balance between research and the business need. There were variables that were significant in bivariate and then not in the model. And so these are kind of future work, and Shuba may touch on this a little bit more, but we also saw some change in directionality. I think that a couple of things that I would note here, because I'm getting close to time, is that in this, there are some unexpected results. So for example, with income inequality, the income inequality ratio is the household income at the 80th percentile divided by the household income at the 20th percentile. An increase implies increased income inequality. However, an increase in income inequality seems to cause a decrease in chronic disease. And the same is true with access to exercise. So some of these are a little bit counterintuitive, but you'll notice that the others tend to fit with what we think. And those two, they actually hold between both the chronic disease model as well as the comorbidity model. You'll notice here though that in the comorbidity model, the caregiver type agency provider, which means that they're hired by an actual agency rather than working individually, that particular variable is no longer significant in this model, and neither is the percentage of rural or rurality within a Washington County. I'm going to toss this back to Shuba for the sake of time. I'm happy to talk more about the models whenever, though, if you guys want to reach out. But I'd like to let her walk through the visualization some.
Yeah, thank you, Charles. Yeah, so now that we did this analysis, and also to say that the visualization is based on the bivariate analysis and not the multivariate model that Charles presented before. So it shows like 1:1 relationship between the county health data and the HCA data. So this is a model that we built. This is a visualization we created on Tableau. And so you can see that on the right, we have we have a list of social determinant of health variables. On the left, we have a list of all these conditions. And so suppose if the organization wants to develop a program around, wants to target diabetes and wants to target diabetes as a condition, because, we have a lot of claims that comes from diabetes. So, and maybe there is a lot of evidence that physical activity reduces your risk of having a diabetes or helps maintain diabetes. So if our leadership looks at this dashboard, and maybe even a program manager looks at this dashboard, I think this is a very intuitive dashboard, because, for example, if I want to do this a program around physical activity, do I do it on the counties that are marked in gray, for example, the Jefferson County on the left, or do I do it in the counties that are marked in in maroon, I would say, for Yakima County. Of course, I would not do it in the counties that are grayed out, because those are the counties which have high access to physical activity and they have very low prevalence of also chronic disease. So, so if I want to make an impact on the claims that are getting generated and to improve health outcomes of the HCAs living in those areas, I would definitely focus on counties such as Yakima County rather than focus on counties. So you can see that a tool like this, it's very easily being done, can actually help the organization in terms of resource allocation. Also for a program manager to decide which of the counties they want to focus on. For a carriers to decide maybe something is going wrong in Yakima County. And we know that there are a lot of other social determinant variables too that impact, but definitely this is something that the physicians maybe who are practicing in Yakima County can actually take a different strategy in talking to the patients who come in with a lot of diabetes claims, or Kaiser or Aetna can have a different program or a wellness program, a wraparound wellness program that's more focused in the Yakima County compared to doing something in the Jefferson County. So there's a real use case of this, and the organization is currently using it to making some of the decisions of interest. Charles, the next one. So limitations, of course, you know, this work definitely has some limitations, and most of it is that we only use the diagnostic, the data, and we did not use any kind of prescription data. And you know, like if you can have a chronic disease and you might not go to the hospital for a year, but you might be managing your disease using medication, and that is not getting captured here. So maybe if you include the prescription data, the prevalence rate might just increase. And then, of course, you know, as Charles alluded to, the fact that the bivariate and the multivariate, in the bivariate model and the multivariate model, some of the variables change directions. So that means that there may be some other underlying factors that may be impacting the outcome, the outcomes that are to be seen. So the next goal is definitely to create visualizations that also have an interaction functionality, to see like what programs and what kind of benefits we want to do in conjunction to impact the health in a particular community. Charles, would you want to add any more of the limitations of this work?
No, I think you've touched on them. Thank you, Shubha.
Okay, and so the next one slide then. And so as a next step, you know, we have Milliman has agreed to take over this work, and now they are going to continually generate these kind of dashboards for us. So I think it's a great way to integrate work that we did at the organizational level to be taken up by Milliman, and then including it in the workflow and generating both longitudinal information as well as, you know, and also addressing some of the limitations that we had, because we have asked Milliman to also include the prescription data. So some of the limitations that we had can be addressed by them. So I think this work is moving forward. So, and so in conclusion, I would say that, you know, it's important, especially for organizations like us, which are very resource strapped. So to find out these unique ways of using resources that are there and creating these very cost-effective solutions, and something that is, you know, replicable and something that is backed by research. And yeah, so thank you. And here are our contacts. If you have any questions, please reach out to Charles and me for further questions. Thank you, Andrea.
Well, thank you all. That was all fascinating stuff. We have a couple questions in the chat, and I will start with a question for Sam. The questioner asks, I noticed on the Washington State map some color variation within certain counties. Is that because the data is at different levels of granularity?
I'll share my screen now just to highlight, I think, what you're referring to here. So it's actually, I think, just an artifact of the way that the boundaries are drawn. You can see here, like for coastal actually in this case it's legislative districts, but for coastal districts, it kind of draws around the edge of the land and into the sea. So I'm assuming that's what you meant by color variation, but if not, please let me know.
And we have a question for Charles. What is the best way to include both ICD-9 and ICD-10 codes in research? The prevalence of comorbid conditions may be different based on ICD-9 versus ICD-10, as ICD-10 codes are more detailed, which is an interesting question.
Yeah, quick plug. NATO has an ICD-9-10 conversion tool if you're interested, so feel free to contact me. For us, though, we were using data where it just wasn't relevant, essentially the benefits group. We were, both for, I think, just recency, but also data completeness and for a few different reasons, the way that the number of carriers had changed and ultimately wanting to bring all of the carriers into the fold. We kind of just dodged this problem by focusing on the post-conversion period. But if I had to do it, I would use a conversion tool and then go from there.
I imagine I missed this in your slides. What was your time series in?
16 to 18.
Oh, okay.
And the conversion happened in October of 2015.
Right on mark.
It sure did. Here, data. Did you have something? Sorry, Shubha? No, okay. Excuse me. So of course, for the participants, if you have, any more questions, please keep them coming. Alberto and Sydney, I was wondering if you could share a little bit more about what's next for the tool and your team's vision. I noticed you mentioned COVID-19 information being something that was up and coming, which obviously makes a lot of sense, but wanted to give the opportunity to expand on that.
I'm sure. So I can continue, Sydney. But we really welcome feedback. As we noted, this is a living tool, and part of what we want to do is ensure that the tool is usable and that it's meeting the needs of as many individuals as possible. So please give us feedback if you have any thoughts about either the data you would like, if anything's unclear, if you have any suggestions for us for improvement. That's one of our next steps. As well as maintaining the latest data and adding additional variables on there. One of the key things also that we didn't get to mention is just the evidence keeps evolving. So with that evidence, we need to make sure that we keep our tool relevant. And so we keep monitoring the research and making sure that it is up to date.
You're on mute, Andrea.
Thank you. I'm noticing a request in the chat for a link to the conversion tool that NATO uses. So that would be great.
Yeah, it's on it's on the website. I'll put it in the chat. And just for what it's worth, we don't use it much, but we developed it in conjunction with some researchers. So.
Well, 2015 is getting to be a long time ago, but yeah. So Shubha and Charles, what surprised you the most in your results, your work?
So I can start, and Charles, you can pitch in. I think the most important thing that we saw is how some of the relationships changed directions. We started with the bivariate and we were very excited, but then when we created a multivariate model, the relationships went the other way around. And I see that, like, all of us here are social determinant specialists. So, like, there's no end to the number of social factors, and a lot of them are interconnected and one leads to the other. So it could be like a lot of factors might be interacting and creating a change in the direction of the effect. And so our goal next is actually to dig in further, look at some of the other background analysis we did in terms of correlation and stuff, and seeing like how and what factors might potentially be resulting in changing of the directions, and of course refining and using that to refine both the dashboard and that. So I think it's a change in direction, which was like, oh, why did it happen? and so that's something was very interesting, but most of the relationships were in the direction that we expected. And the other thing is also the county health ranking. As you know, it aggregates a lot of variables to create an indicator. So it could be that an indicator that we used was not the best indicator for the purposes. So I think we need to do some more digging around as to why the results kind of changed. So Charles, do you have anything to add to that? I know you are.
I'm kind of juggling, but no, I agree. I think the switch in directionality and some of just the things that seemed a little bit counterintuitive, those raise interesting questions about just what we could do next to get, I think, probably more granular data or maybe more timely. But yeah, I thought that was interesting.
So Sam, I was hoping to start a conversation with you about some of the data privacy aspects of the work that you had done in Washington. I mean, it's still a minimum cell size of 30 certainly seems more than large enough to be quite safe. But you were talking about again that trade-off of flexibility of with the in maintaining the just maintaining cell size, and just was wondering a little bit, wanted to, if you could share a little bit more. You had mentioned, for example, the age bands, and what were some of the other challenges that you ran into in just maintaining cell size and the privacy, statistical de-identification, essentially, side of things.
Yeah, I can speak to that a little more. And to reiterate, this is a very pro data security presentation and organization here. We love data security. But like you said, I mean, it's always kind of a balancing act between what elements you can retain and how secure your data is, and what your acceptable thresholds are for security. So there's a lot of really well documented ways that you can make a publicly available data set out of an initial analysis file. Safe Harbor is one example where there's literally just a list of here's all the data elements you need to remove to satisfy these requirements. Again, if you were at the conference last year and attended the specific session on public use data sets, some of this might be familiar, but an alternative method to the very straightforward and structured Safe Harbor method is to perform what's called expert determination de-identification, where you work with ideally somebody who is a qualified statistician to determine what data elements you can retain in your data set while meeting a predetermined threshold for risk of data re-identification. So that's often a very iterative process where you slowly refine and hone the data elements that you're going to retain in that set, and that can, if you're absolutely determined that I need to have this specific data element, if it's something that tends to be more re-identifiable than others, something like race or something that's very granular, not necessarily age, because that's fairly easy to group, but something that has a lot of different levels. If you're absolutely determined to have that, you can usually find a way to make that work, but you end up trading off with other things that you might need to drop in order to reduce that re-identification risk.
If I can chime in as well, also, like, one of the interesting pieces about that question is what's happening with dynamic dashboards, where you don't know what level of granularity somebody will want. And if you roll data up, you have enough de-identification and enough of a cell size, but not if you drill down. And one of the cool features of tools like Tableau is that you can specify when to show the data and when to retract it based on like specific row level rules that you set. So it's a really cool new world that we're getting into that allows us to be more flexible with data.
Yeah, that's a really good point. Tableau makes it a lot easier to deal with that, where you don't necessarily have to have that that level of pre-aggregation done on your base data set. I think one of the challenges we faced with this project was that we needed to demonstrate that even the data behind the reports we had to assume that it was going to be publicly available, even if it wasn't explicitly made available. So we needed to make sure that we weren't able to leverage those features of Tableau as much as we would have liked.
Meaning assumed the underlying data could.
Yeah, exactly. The underlying data had to be rolled up pretty substantially.
Yeah. Interesting stuff. Okay. I'm not seeing anything else come through in the chat. We do have a couple more minutes. If any of the panelists have any questions for each other or any other comments they'd like to leave the group with about their work. Well, with that, I think I'll thank all of our panelists very much. It's been this great work that you're doing and fascinating to hear about. And with that, I'll throw it back to Charles for any announcements about our very last session, which is coming up in a few minutes.
Yeah, let me make a bunch of plugs since I've got a minute. Thank you, Andrea, for moderating. Let me also thank again the sponsor of the session, the Healthcare Cost Institute. And then I have a few different things to plug, actually. Speaking of sponsors, the exhibit hall is still open. If you haven't had a chance, please go take a look and see what folks have to offer. And then there is, this feels funny plugging this now, but there is a session survey in Excel events. If you want to give us some feedback, that would be great. I would genuinely appreciate it, so please. And then also we have a post-conference workshop on innovative analytics and multi-state collaboration that's scheduled for October 1st and 2nd. I posted the sign up in the feed yesterday and the chat, and I probably will do that again before the closing plenary starts. And that is the last thing. We will start the closing plenary in just a moment. So I will see all of you over there. Thank you.
All right, thank you, everyone.